Hello, everyone, and welcome to another episode of Infectious Conversations, the WVU Medicine Infectious Diseases podcast. I'm going to be your host today. I'm Catessa Howard, our lead antimicrobial stewardship pharmacist, and I'm accompanied by my esteemed colleague, Dr. Drew Ward. You may remember Drew from one of our very first podcast episodes where you and I talked about antimicrobial stewardship, so thanks for coming back on the podcast today. But since we might have some new listeners this time, Drew, why don't you introduce yourself, talk about your role here at WVU Medicine, how long you've been here, and then, of course, like we always do on the podcast, a fun fact.
Sure. Yeah. I'm glad to be back. So my name's Drew. Drew Ward. I'm an infectious diseases clinical pharmacist, and I've been at WVU Medicine for nearly 6 years at this point, either training in my residency programs or as a clinical pharmacist, the position I hold today. I do a lot of work with the inpatient antimicrobial stewardship efforts and some of our other programs like OPAT and COPAT, which assist with monitoring outpatient antimicrobial therapy for our patients.
Great.
My fun fact, I forgot.
Yeah, you can't get away that easy.
I can't get away from it. My fun fact, I've been working around UTI stewardship for probably around 5 years now, all the way back to my second year residency training.
Yes, I think that we started some of the project work that we're going to talk about today during your residency year when you were on rotation with me. So I'm glad to see it come to fruition, but I don't want to give it away too quick.
No,
we'll talk about it later. All right. So thanks so much for that introduction, Drew, and leading into what we're going to talk about today on the podcast. I think this is going to be a super exciting episode. We're going to dive into one of the most common infectious diseases that we see both on the inpatient setting and the outpatient setting. Urinary tract infections. And this disease state is exciting from an antimicrobial stewardship perspective because the UTIs are really deceptively simple, but they are full of nuance. So I think that we're going to touch a lot on that today and can clear up some things for our listeners and clinicians and provide some really great insight. So, Drew, you recently updated our UTI guidance for adults here at WVU Medicine and deployed some diagnostic stewardship for urine cultures. So that's what we're going to focus on the podcast today. But I think the first question that we have to start this podcast with is, what has to be present for someone to have a urinary tract infection?
Yeah, the most important question when we're thinking about diagnosing a UTI. So they have to have symptoms of some sort, whether that be that of a lower urinary tract infection that we call cystitis frequently, who may present a patient with this could have dysuria, a suprapubic tenderness or pressure, maybe an urge to urinate frequently, or that of an upper urinary tract infection. Sometimes we call those pyelonephritis. That's an infection of the kidney. And they're a bit more unique in that they can often present with flank pain or pain around the sides, what we call costovertebral angle tenderness. So that's pain kind of back towards the back section that can is really a radiation of the pain due to the kidney infection in that area. People with pyelonephritis, those kidney infections, they're going to be more likely to have systemic symptoms, things like fevers, chills, but also may present with some of those symptoms that patients with just a cystitis might have. So they could still have painful urination or dysuria, or they still may have an urge to urinate more frequently. Then we kind of get into a sort of separate realm with catheter-associated UTI. So having an indwelling catheter, such as a Foley catheter itself, is a risk for developing urinary tract infections. And symptoms of those infections are pretty similar to that of cystitis, but notably with the presence of an indwelling catheter.
Great. Thank you so much for breaking that down. I think those are three main groups, right, of symptoms that we have to think about. But a great way to remember this is keeping in mind a common catchphrase that has been coined by different ID specialists throughout the country, even referenced by the CDC in some of their educational materials. And I think that you've probably heard me say this since you've been a resident here, but symptom-free pee, let it be. And that is a great way to remember if someone has asymptomatic bacteriuria or ASB, we let it be and we don't need to treat it. But that I want to ask you, Drew. So say someone has asymptomatic bacteriuria. What patient populations do we actually need to treat that in?
Sure. So the vast majority of patients with ASB we're not going to treat. And we'll touch on a few of the reasons why throughout the rest of our episode today. But some people it is worth treating, even just as a quick definition. So ASB or asymptomatic bacteriuria is exactly what it says it is. It's the presence of significant bacteria in the urine. And people who may need that treated include people who are pregnant, those who've had a recent or anticipated urologic procedure, anyone who's had a kidney transplant within the last month or so, and some patients who are immunocompromised or immunosuppressed, where their body may not produce the white blood cells needed to clear that bacteria on its own.
Great. Thank you for going through those. I think that's important to remember. With anything in ID, there's always caveats. I'm glad we put those out there. Great. So the next question I have is, I know that the Infectious Diseases Society of America just released some urinary tract infection updates in their guidance or the guidelines, and that helped shaped our guideline update. Can you talk about the updates around diagnosis?
Yeah, sure. So we were eagerly anticipating this update from the IDSA for several years for the very reasons we'll talk about. So diagnosis is kind of the key thing I feel this document published by the IDSA hits on. It was published last summer. And previously, when we think about diagnosis of UTI, there were a number of buckets that you could consider a patient within in order to diagnose their infection. And it was a little bit complicated relating the diagnosis to maybe what empiric treatment you want to put a patient on when treating UTI. Some of these groups included uncomplicated UTI, complicated UTI, complicated pyelonephritis, uncomplicated pyelonephritis, CODI, just to name a few. And so making those decisions regarding empiric and definitive treatments could be a bit tricky. Historically, also, males were always grouped kind of automatically in the complicated UTI bucket, but we know now that's probably not necessary, especially if they're exhibiting symptoms similar to any other patient with an uncomplicated UTI. So that was then. The now is IDSA has proposed grouping UTI into really just two buckets. You can think of it as a bucket for uncomplicated UTI, which is defined as a simple cystitis. That's an infection confined exclusively to the bladder, so no involvement of your kidneys or anything like that. And that patient with cystitis only will have localized symptoms, so things like dysuria or suprapubic tenderness. They're not, if they have systemic symptoms, if they have fever, if they have chills, or if they have symptoms that might indicate a pyelonephritis, like the flank pain that we talked about earlier, they would fall in the complicated UTI bucket. So I think the best way to remember this is knowing what constitutes an uncomplicated UTI, and then complicated UTI is now pretty much anything else. That could be a pyelonephritis, catheter-associated UTI, pyelonephritis, as I mentioned, or a prostatitis. Anyone with a fever or altered mental status who presents with a UTI, those would be considered complicated. So this really streamlines, and we'll show you how it does in a little bit, the decision-making, especially when it comes to choosing an empiric antibiotic for the UTI we're treating.
Yeah, I really like their update because I felt like before it was a bit too complicated as a play on words. But now just having those two buckets it falls in, I think really helps us diagnose them a bit easier and then also pick that empiric treatment option. So now that we've discussed symptoms and diagnosis, let's get to the fun part and where stewardship can really shine, and that's in treatment. So would you like to pull up the updated WVU Medicine UTI guidelines on MedCompass and walk our listeners through it?
Yeah, sure. Let's take a look at it.
Okay, great. All right, Drew, so we've got MedCompass pulled up. To get to the adult infectious diseases guidance, click on the bubble here that says adult medicine ID guidance. And there's a few different ways you can get to our UTI guidelines. You can search here above, which would search just on this page, but I'm going to take you the easiest way by just scrolling down to our UTI guidance folder, and then we just have the one document in here. So I'm going to pull this up, and you can see here this is our inpatient and and outpatient guidance. We talk a lot about in the key points things that we already went over in the first part of the podcast today. But I think the first question I have for you is, how do local resistance patterns influence our UTI antibiotic choice?
Sure. Yeah, they're very, very important. So one of the things that we can do to assess local resistance patterns is use something called an antibiogram, which is an easy to read document or table that essentially lists the percent of recent bacterial isolates from the urine, in this case, that are going to be susceptible or treatable with a certain antibiotic.
Okay.
A good example of this, just to provide one, is E. coli. So E. coli is a gram-negative bacteria. It's the most common cause of urinary tract infection pretty much across the board. Some local antibiograms might indicate that the susceptibility rate in their community of certain E. coli isolates is less than 80% to certain antibiotics. So typically that would mean if your antibiogram lists a percentage less than 80 for a specific organism corresponding with a specific antibiotic, then we really shouldn't use that empirically or definitively to treat that particular bacteria. A good example here locally is Bactrim. So it's an agent that we often use for UTI, but unfortunately, our susceptibility rates here for E. coli to Bactrim are around the 72-73% range. So that's why we don't really use it preferentially as empiric treatment for certain urinary tract infections.
Yeah, thanks so much, Drew, for bringing that up. I think that you bring a great point up with that. I think it's great to check the antibiograms, because if we get the empiric therapy up front, right, then we don't have to switch, right, when the culture comes back. So perfect, great. And then I think we walking through the guidance a little bit, we have reviewing the patient's prior urine cultures as well. This can be helpful, especially because a lot of times our patients may have those recurrent urinary tract infections. So their own microbiology can help guide that empiric therapy too. So I'm going to scroll down a bit, and I want to talk through the first-line therapies for uncomplicated cystitis. So we talk about uncomplicated UTIs. If you want to reference the great definitions that you already gave from the IDSA, that's in table 1 here. But go ahead and tell us what the first-line therapies would be for uncomplicated cystitis.
Sure. Yeah. As you can see on the screen, our first-line therapy really for any uncomplicated cystitis, unless there's a contraindication, as we'll talk about, is nitrofurantoin. Its brand name often referred to as Macrobid. It's an easy antimicrobial to take. It's given twice a day and typically used for 5 days when treating uncomplicated cystitis. And the best thing about Macrobid is that it has a spectrum of activity that will kill a lot of the organisms that we associate with UTI, most notably E. coli and another organism called Enterococcus that is a gram-positive organism, but also is often implicated in urinary tract infection. It's got a lot fewer side effects than some of the other agents listed in this table, mostly because it concentrates really well in the bladder, and so we don't have to worry about systemic side effects that you might see with other antimicrobials.
Great. So that's like a steward's dream, right? You're getting great concentrations at the site of infection without collateral damage elsewhere in the body. I would like to say that Macrobid's one of my favorite options for treatment for UTIs because of that. Great. And I think the one thing I'd like to point out here too for the alternatives, we have cephalexin and Bactrim, as you mentioned, and then for IV is cefazolin with some footnotes. And that says if your local susceptibilities prove greater than 80% susceptible for E. coli. So always good to look through that. So I want to jump into this, and I think this is something we see a lot. We see a lot of ceftriaxone used on the inpatient setting for empiric UTI treatment. Why is ceftriaxone not the magic bullet, and what are some alternatives to that?
Yeah, ceftriaxone is easy, right? I mean, even if we're using it multiple days in a row, it's only given IV once a day. But it doesn't cover everything that we really probably should cover empirically when thinking of a urinary tract infection. So for one, ceftriaxone and any cephalosporin listed on this document or that we commonly think of they don't cover Enterococcus, that gram-positive organism I talked about earlier. Notably, ceftriaxone has a higher incidence of systemic side effects compared to alternative agents that we list as preferred or alternates on our guidance document, notably C. diff infection. And while you might think that the incidence of C. diff would be low if we're only giving this for 1 or 2 days, remember that every day of antibiotics matter when it comes to putting a patient at risk for developing C. diff.
Great. Thank you. So you see here that we have ampicillin and tobramycin or gentamicin if facilities only have that aminoglycoside. Why would that be preferred over, because that's more frequent dosing with the ampicillin, and aminoglycosides sometimes have side effects associated with them, notably nephrotoxicity. It gets a bad rap for that, although that could be a point of debate. But why would you prefer that regimen over ceftriaxone?
Yeah, a few reasons. So it's a great empiric regimen because it will cover organisms we associate with UTI, whether it be cystitis, pyelonephritis, CODI, anything like that. The ampicillin component works as a drug of choice for Enterococcus, which is something we already addressed ceftriaxone does not cover. And it also has activity against some of the gram-negatives we think of some of the time in UTI. But the real workhorse for the gram-negatives is the tobramycin or the gentamicin. Mm-hmm. So that's an aminoglycoside antibiotic that often retains activity to most gram-negative pathogens that could cause UTI, including E. coli, and including those gram-negatives that can sometimes express what we call extended spectrum beta-lactamases, which essentially means it's a bacteria that has this gene turned on that's going to eat up a bunch of our commonly used or less broad antibiotics.
Great. Yeah. Yes. And I like tobramycin for the same reasons that you mentioned. And also it has a similar property as macrobid as it concentrates super well in the urine without getting concentrations other places, notably the gut. Mm-hmm. So it has a very low C. diff potential. Mm-hmm.
Exactly.
So wins all around. Great. So you mentioned that you would talk about when macrobid is not the right choice. Can you talk a little bit more about that?
Yeah, sure. So we've spent a whole 5 minutes or so bragging on it, but there are some instances where we would probably avoid macrobid. Mm-hmm. So one of those is if you have an infection of the upper urinary tract or the kidney, so a pyelonephritis. Mm-hmm. We talked about how well macrobid concentrates in the bladder. Mm-hmm. The downside to that is it doesn't hang around in the kidney tissue very long. So if you have an infection of the or of the kidney, macrobid's not going to stay long at that site of infection for it to work. Obviously, if a patient has a reliably documented allergy to macrobid, we're going to want to avoid that. Mm-hmm. If we know, and you mentioned this earlier, looking back in the 3 to 6 month period, if it's a patient who's apt to have recurrent UTIs and they were to grow an organism in that recent time frame that's resistant to nitrofurantoin or macrobid, then we wouldn't want to use it then either.
Great. Yeah. I think something I see commonly is, Proteus, right? And macrobid doesn't have any activity against that. So that's just the one caveat. But other than those things, it's a winner. It's a winner for stewardship and a winner for our patients. Great. All right. So I don't think that there was anything. Oh, when would you want to start a bit broader? So we've talked about more narrow spectrum agents. When is it more appropriate to consider more broad therapy up front?
Yeah, so it falls in line with that thought process of looking back in the last 3 to 6 months or so of a patient's microbiology history. Mm-hmm. So sometimes patients will have grown things like an ESBL E. coli or a CRE, heaven forbid, in which we might not be able to use those regimens we recommend as first or second line, like the ceftriaxones, the ampicillin and tobramycin, for example. And in those cases, you'd want to use maybe a bit broader agent based on the susceptibility reports of those earlier microbes.
Sure. Sure. And I think that one table that I really like in here is the culture-guided therapy for these uncommon organisms. So if that's what the patient ends up growing, or if they have a previous history of it, this gives you some recommendations.
Yep. It's all there.
It is.
It's the only tool you need.
This guideline, for sure. And then, of course, if patients are coming in with sepsis or from a healthcare-associated or recent urologic procedure, and then septic shock from urinary source, you may start with our broader beta-lactams.
Absolutely.
And then, of course, though, I think the main point here is to follow those urine cultures for optimal therapy and duration of therapy.
Yeah.
Great.
Awesome.
Anything else you wanted to point out on the guidance document?
No, I mean, we could spend multiple episodes going through it if we wanted to geek out about it, but I think that covers most of the basics.
Yeah, we won't keep our listeners that long today, even though I know we're both very passionate. So the one thing we don't include on here, though, is what antibiotics should you not use for a urinary tract infection?
Yeah, there are a few classes and antibiotics that we wouldn't use for UTI. Some of those include moxifloxacin. So if you remember back to when we were looking at the guidance document, ciprofloxacin and levofloxacin can kind of be considered its sister antibiotics. We can't use this one because moxifloxacin doesn't concentrate well in the genitourinary system. So it's not going to get to the site of infection to treat a UTI. Another class are things, really any tetracycline antibiotics. So there are several of those that you might come across in practice. They could be doxycycline, minocycline, ometacycline, your IV tetracycline derivatives like tigecycline or eravacycline also aren't the best to use for urinary tract infection because they just don't get in the GU system very well.
Yeah, great. I think that's really important to mention too, because those are commonly used antibiotics, all of those, and just understanding that if they don't get to where they need to treat, then we shouldn't use them. So thanks for pointing that out, Drew. So I'm going to switch gears for a little bit. We've talked a lot about urinary tract infection diagnosis and now treatment. We've geeked out, like you said, about some stewardship pearls. But I want to talk about urine culture diagnostic stewardship. So what is WVU Medicine doing in terms of diagnostic stewardship to realign our urine culture reflex criteria to best mimic best practices?
Yeah, so this initiative, as it was born out today, kind of started back nearly 4 or 5 years ago, back when I was a resident, just training in infectious diseases. So at that time, we did a literature review on how we can best refine our urinalysis reflex to urine culture criterion. There have been a lot of publications then and since then, and expert recommendations that indicate that we really should only focus on one piece of the urinalysis when considering urine culture reflex, and that's the presence of pyuria. Pyuria, which is just white blood cells present in the urine, when it's absent, we know that it has a high negative predictive value for actual UTI. And so as a result, the urine culture, urinalysis reflex to urine culture criteria that we recently implemented only picks out that pyuria piece from a urinalysis performed. And essentially, the urine culture is only reflex to if there are white blood cell counts greater than 10 per high-powered field in microscopic analysis of the urine.
Great. Yeah, I think that there is a lot of interest around diagnostic stewardship, especially even in the antimicrobial stewardship world, because if we obtain a UA as reflex as part of that differential diagnostic workup, right? People come in all the time. We don't really know what is going on with them at the moment. We order a ton of tests, a lot of times that being a urinalysis with reflex to culture. And by refining this urine culture reflex criteria, we can more successfully limit those urine cultures being performed on patients with that low pre-test likelihood of a UTI. Because like you mentioned, if the white blood cell count in the urine is less than 10, it has a really high negative predictive value for an actual UTI. And I think this is really important to bring up. We're a very large health system, and we had varying degrees of UA with or urinalysis reflex criteria previously. And now that we're all aligned on the same, it makes streamlined care across our health system.
Yeah, absolutely.
Great. So I like to give a kudos and shout out to you, Drew, for sticking with us from the time you were a resident all the way from our initial conversations and bringing it up at many different stewardship meetings to ultimately making this a enterprise antimicrobial stewardship goal this year. But I also want to give a couple different shout outs too to other folks that had a huge play in this and our key stakeholders. Without them, this wouldn't have been possible. So our lab affinity group across the system, Dr. Matt Locant, our system epidemiologist and ACQO of antimicrobial stewardship and infection prevention, Nina Huss and Dr. Jamie Pinkovich. They were key in making this initiative feasible and getting it into action. And we're really excited to see the results. When did we go live with this?
This was January 7th. So at time of recording, about 2 or 3 weeks ago.
Great. We wait with bated breath on the results, but I think this is a really great change. And we're really following the literature and best practices here so we can best serve our patients.
Absolutely.
Great. All right. So something new I think we're going to do today as we wrap up. We're going to end with a lightning round of questions. So I'm going to ask you them, and you have to tell me the first thing that pops in your mind. Okay.
Got it.
Most overused antibiotics for UTIs.
Ceftriaxone.
Most common mistake you see in practice.
Using the presence of pyuria to diagnose a UTI on its own and not considering the symptoms the patient has.
Perfect. One stewardship takeaway every clinician should remember.
You said it earlier, symptom-free P, let it be.
Great. I think we should get shirts with that made for next Antibiotic Awareness Week. We'll see how that goes. But with that, we have wrapped up another episode of the podcast. Thank you, Drew, for joining us today and enlightening our listeners on pertinent updates around UTI diagnosis, management, and our newest diagnostic stewardship endeavor. And thank you all for listening in or watching. We really appreciate you joining in our podcast, and tune in next time for another episode of Infectious Conversations. Thanks, Drew.
Thank you.